So now a few words about the extension of the FAST examination. So the examination of the lungs. So what type of acoustic windows and where we've got in the ultrasound of lungs? So we've got 3 points on each side. So 3 views on each side. So together 6 places where you will check the lungs with the ultrasound, and they're really similar to the places in which you put your stethoscope. As ultrasound is called like stethoscope of the 21st century, it's quite easy to remember. So put the ultrasound on the lungs in the places where you usually would put your stethoscope. And actually the examination is quite similar because we are searching for some kind of symmetry between both sides of the lungs. So we've got 3 points. So the upper anterior point, which is between the third and fourth fingers of the upper head at the base of the finger. So it's around, let's like in the mid-clavicle line, in like second intercostal space. Then the lower arterial point is in the middle of the lower hand. So when you put your 2 hands, so in the middle of the lower hand will be the lower anterior point. So it's the level of nipple, let's say, and like anterior axillary line, I would say so. And then we've got the PLAPS point, which is in the posterior axillary line, in the place where perpendicular intersection of the posterior axillary line and the line intersecting the lower anterior point come together. So I would say in the posterior axial line and the level of the fifth intercostal space, something, let's say, like that. So those 3 points on each side. And for the examination of the lung, you can use or linear or phased array transducer. As I told you before, I use the phased array transducer in the helicopter because that's the only one I've got, and it works. So when I use this phased array transducer, the probes marker should be towards the patient's head, and I look for a few things in the view. I look for the butt sign, so the lung between the shadows of 2 ribs. I will show you that. I look for the lung sliding, which is the proof that the lung moves and that there is no pneumothorax. I look for the lung point. If I suspect the pneumothorax, I search for the A lines or B lines, and I use the M mode to check for the signs of pneumothorax. So those 5 things to look for when you perform the lung views of the using the ultrasound. So let's go through this film. So as you can see here, you can see the lung sliding, so the movement of the pulmonary pleura. So marker towards the head, and you have to put it between the ribs, but you will have the echo, hypoechogenic echo of 2 ribs on your picture. So those are the ribs, and this is the hypoechogenic ribs. Here we've got the pulmonary pleura, which moves when the patient is breathing, so you can see this movement, and it's called sliding of the pleura. And when you see the sliding of the pleura, it means that there's no gas between the thorax wall and the lung, so it excludes the pneumothorax. Okay, so first of all, when you put a probe, search for the butt sign. So here you've got the rib, the echo of the rib, and here you've got the lung, lung tissue. Okay, so look for the butt sign, and after let's say finding the butt sign, then you know that you are looking at the lung, so you can assess the lung. So that's the first thing to do. And you can see here the rib, the chest wall, and the pleural line. Then look for the lung sliding. So the normal view, it looks like that. You can see that there is some movement here, movement of the pulmonary pleura. Okay, so the lung, when the patient is breathing, is moving over the chest, and we can see it when there is no gas between lung and the chest wall. But when it's absent, it looks like that. Okay, so there's no movement of the pleura, no movement of the pleura. And in the trauma patient, we should think about the pneumothorax. And if together with this sign, we've got some silence on this side, the trauma is on this side, we should consider pneumothorax. And if the patient is in shock and have lower conscious level and respiratory problem, that's, let's say, the time you have to decide to perform tube tracheostomy. Then if you do not see sliding, it's good to search for the lung point. The lung point is the point at which the pneumothorax finishes, the point at which there's no gas and the part of the lung touches the wall of the chest. And when you see the lung point, it means that you can be sure that there is pneumothorax. So here you can see, here there is no movement of the pleura, and here you can see the movement of the pleura. So here the lung touches the wall of the chest, and here it doesn't because of the gas. So that's the borderline between, let's say, the gas, the pneumothorax, and the lung touching the wall. One more time. So here we got, there was pleura sliding, and here there's no sliding. Sliding, no sliding. Gas here, lung touching the wall. And to confirm the pneumothorax, you can switch on the ultrasound to M mode. And in the M mode, the normal view is the seizure sign. So here we've got the lung, which is in constant movement while when the patient is breathing or you ventilate the patient. So it moves, so it looks like sand. It looks like sand, okay? And here we've got the sea. So feel like comfortable situation, like on holidays by the sea. You can remember it like that. That's the norm. And when it comes to pneumothorax, you've got stratospheric view, stratospheric sign. So you do not have the sand. You are in the ocean. Okay, there's only sea, only, let's say, ocean. So like drowning. So it's not a good sign, and it's a sign of pneumothorax. So no sliding, stratospheric sign confirms the pneumothorax. One more time, M mode, so seizure view and stratospheric sign. Then another thing you can look for are A lines and B lines. A lines are normal, it's norm. The A lines are horizontal, hyper-echogenic reverberation of the pleural line. So here you can see A lines, these horizontal lines. That's the normal sign. There is no fluid in the lung. And the B lines are characteristic for the wet lung. So when you, maybe not in trauma patient, but when you've got a patient with the crackles on auscultation, when you suspect, and those crackles are bilateral, you suspect pulmonary edema, you probably, in pulmonary edema, you would find the B lines. So B lines are the comet tail vertical lines, and they are hyperechogenic, extended from the pleural line, and there are effects of thickened interlobular septa, which are thickening in pulmonary edema. They are also thickening in the pneumonia, but then you would have B lines on one side of the chest in, let's say, one lobe. So maybe one more time, I will show you B lines. Those vertical ones. So it's quite, I would say, easy to differentiate between the horizontal lines and vertical lines, okay? So it's quite different. here the picture of the B line. So there should be at least 3 B lines to diagnose the problem, to diagnose that the B lines are the problem, and with that we've got, for example, pulmonary edema. So what are the signs of pneumothorax in ultrasound? The absent lung sliding, just to summarize. In M mode, stratospheric signs or absent movement of the pulmonary planula. You would see the A lines, no B lines in pneumothorax, and you should search for the lung point. So it's a place where pneumothorax ends, and it depends on the breathing phase where it is when it appears. So it appear and disappear during the inhalation. And here I'll show you the myself performing the ultrasound. It's in helicopter. So in a moment I will turn the voice. So I'm performing the examination of the lungs. Just I reassess the patient. So that's the head of the patient in the helicopter. The position of the doctor is not as in the hospital, so you have to put a prop in the proper place. That's the monitor, so it's quite handy. And it's quite noisy inside a helicopter also.